Chair. I'd like to introduce Dr. Deepak Gorakhana, who is trained in gastroenterology in Birmingham, Liverpool, and Northeast England. He's a consultant gastroenterologist in Scotland, East, Northeast of England. His interests are in inflammatory bowel disease in particular and therapeutic endoscopy. He has a role in college faculty, nutrition young fellows, and now as the secretary.
Good morning. Firstly, I'd like to thank you for the excellent invitation to address this meeting. It's a pleasure to return to Jordan, having been here in 2012. It's an extremely well-run meeting, and I hope that the rest of the meeting goes equally well. I've been asked to speak on the management of inflammatory bowel disease. The potential scope of the talk is vast, and I could probably spend the rest of today speaking to you, and you'll all be anaesthetised by then. The potential topics will include pathogenesis, the differential diagnosis of inflammatory bowel disease, extraintestinal manifestations, the difficult issues of pregnancy and lactation, cancer surveillance, drug therapies and surgery. Obviously too vast for a 20 to 25 minute talk. So I'm really going to try and focus down on 4 to 5 areas. That's the differential diagnosis, cancer surveillance, drug therapy, surgery, and then finish off with a couple of challenging cases. Really, to start off, the differential diagnosis of colitis is probably ignored. People get stuck with a label of colitis very easily, and it's almost with them forever. The danger is that the treatment level can increase inappropriately in this group of people. I'd like to start off with one group of patients that are probably misdiagnosed, and that's indeterminate colitis. A precise diagnosis of ulcerative colitis or Crohn's disease of the colon is not always possible, either clinically or by histological examination of a resected specimen. This occurs in about 5% of all patients with inflammatory bowel disease, and you may need to send off your specimens for a second read to an expert pathologist. Indeterminate colitis is defined as a disease with clear evidence of inflammatory bowel disease, but insufficient evidence to make a definite diagnosis of ulcerative colitis or Crohn's disease. Long-term studies have shown that up to 10% of patients have their diagnosis change over the period of their lives. The most common reasons for difficulties are sparing of the rectum, confluent mucosal inflammation favouring ulcerative colitis, but then long skip areas that would favour Crohn's disease. Another important and very common disease, especially in the West, is diverticular disease. This is a segmental colitis affecting the sigmoid colon. The inflammatory changes may be mild to florid, resembling inflammatory bowel disease, both endoscopically and histologically. It frequently presents with bloody stools, and some abdominal pain and diarrhea may well also occur. This is normally a self-limiting condition that settles within a few weeks, occasionally a few months, without major recurrence. Optimal therapy is really not known. Common things like a high-fibre diet, antibiotics, and probably 5 ASAs have been used with some success. Microscopic colitis is a diagnosis I think that we're making more and more. We get referred a lot of patients in the UK with, please can you see this patient with diarrhea, either as a routine patient or as a 2-week rule potential cancer diagnosis. And a lot of them have quite normal colons, and we try and get all of our endoscopists to actually take colonic biopsies to get representative samples. Basically, microscopic colitis comprises collagenous colitis and lymphocytic colitis. This is characterized clinically by chronic watery diarrhea and macroscopically normal mucosa with specific histological changes. Collagenous colitis is defined by a thickened subepithelial collagen band with minimal lymphocytic infiltration. Lymphocytic colitis requires an increased number of intraepithelial lymphocytes without a significantly thickened collagen band. The etiologies of both of these conditions is as yet unknown. However, certain drugs such as non-steroidal simvastatin and proton pump inhibitors have been implicated, and there is a well-recognised association between microscopic colitis and celiac disease. Both of these are a common cause of diarrhea in middle-aged women. Both those disorders cause chronic, recurrent, but non-bloody watery diarrhea. There is no increase in mortality or severe deterioration with both of these conditions, and treatment really should be targeted at symptoms. Treatments include the obvious of withdrawing the drugs that could be the cause of the problem, that's non-steroids and particularly proton pump inhibitors, checking serology for celiac disease, and then symptomatic treatment with loperamide. Some of the more severe cases may need slightly more aggressive therapy with a non-absorbable steroid such as budesonide. I would say colectomy is very rarely required. I would say almost never required. I think over the years we've seen more and more cases of radiation colitis come to us. This can occur acutely within 6 weeks of the course of radiotherapy for both male or female lower abdominal cancers. Classic presentations with diarrhea and tenesmus. However, we have seen cases where people have presented approximately 30-odd years after their radiotherapy, and again with diarrhea, bleeding, and tenesmus. They can develop strictures both in the lower small bowel and in the rectum and sigmoid. These can be treated symptomatically with stool softness or colonoscopically by balloon dilatation. Some patients develop troublesome bleeding, and this can be treated by argon plasma coagulation with a couple of therapies being required. Again, a few very unfortunate patients tend to get terrible tenesmus and pain, and there are a variety of enemas, including steroid enemas and sucralfate enemas, that can help them. I'd like to move on to cancer surveillance and inflammatory bowel disease. We live in the internet era. As soon as you tell a patient they have condition Y or X or Y, they'll be onto the internet and looking at all the bad things that can happen to them. And I think the inflammatory bowel disease patients are most worried about developing cancer during their disease. Undoubtedly, there is an increased lifetime risk. This risk is associated with the extent of disease and the duration that the patient has the disease. Colorectal cancer specifically also increases in patients who have coincidental primary sclerosing cholangitis, and the frequency of surveillance drops down to annually in this group of patients. Crohn's colitis, when it affects 50% plus of the colon, is really screened in the same fashion as ulcerative colitis. Screening colonoscopy in the UK starts from about 10 years on, and further procedures are timed on the findings of the previous colonoscopy, so they could be annually, every third or every fifth year. Chromoendoscopy and narrowband imaging has been advocated as a better way of looking for dysplastic tissue by NICE. This requires a little bit of training. It isn't technically too difficult, but probably doubles the time of the colonoscopy. So when scheduling, this has to be scheduled in. I think a simple rule of thumb is if you have no dysplasia on your screening colonoscopy, your risk of colorectal cancer is approximately 2%. However, once you find high-grade dysplasia, your risk increases hugely, up to about 33%. And this is the group of patients who really need to be counselled with regard to a colectomy. I think one of the basic rules here is minimise inflammation, and you probably do reduce patients' cancer risk. There's very good data from the excellent Swedish long-term databases that have shown that if patients are placed on 5-ASA at any dose, then there is a definite reduction in their risk of developing colorectal cancer. This is so-called chemoprotection, or prevention. Sorry. Now moving on to various drug therapies. I think the most important thing is this patient in the hospital because they have a flare of their colitis, or is there a coincidental thing happening? I think I can't stress how important it is to get stool cultures sent off literally from the time of admission. True Love and Wits, I think going back to, I think it was 1968, gave us some fairly simple criteria to define severe acute colitis. This was basically 6 stools per 24 hours, plus 1 or more of the following: a raised temperature, rectal bleeding, tachycardia, anemia, and an elevated ESR. I think the abdominal X-ray has really been undervalued over the years. I think at first presentation it's a very simple, easy way of assessing the severity and the extent of disease. A simple rule of thumb for non-gastroenterologists in the audience is if there's solid feces visible on the plain abdominal X-ray, there is no inflammation in that area of the colon. So if you see an abdominal X-ray with fecal material up the right side across the transverse, and the patient has a flare-up of their colitis, they really have left-sided disease and nothing more than that. The other important use of an abdominal X-ray is obviously looking for toxic megacolon. Toxic megacolon is really a medical emergency, for want of a better phrase. To define it for the non-gastroenterologists in the audience, this is a colon dilated at any segment of greater than 5.5 centimetres, and that's probably the size of 2 vertebrae approximately. This can occur anywhere in the colon, but classically in the transverse colon. If there is any doubt when you assess these patients clinically, you must do an urgent CT abdomen pelvis. I think that's got to be mandatory, particularly in patients who have been on high-dose oral or intravenous steroids. It's well recognised that signs of paratinism can be masked when patients are on high-dose steroids. This group of patients, as well as any acute colitis, needs to be managed with joint care with your surgical colleagues. Obviously, the conventional treatment is with high-dose intravenous steroids at a dose of 100 milligrams intravenously 4 times a day. Higher doses have not been shown to improve outcomes. Tinzaparin is important, and sadly, many years ago, I did see a patient who survived their acute colitis and died of pulmonary embolism. A terribly tragic event, really. Nutrition, again, absolutely vital, either oral supplementation or nasogastric feeding. We must remember that perforation, even in 2014, in the best hospitals, still carries a high mortality. As I've said, conventional therapy is with high-dose intravenous steroids, and if you look at this group of patients, 65% of them will be symptom-free within 5 days. 15% have significant improvement, but a quarter, 25%, will not improve with the standard regime. And I will keep on coming back to this point. At this stage, you're really looking to save lives potentially and not save colon. Severe ulcerative colitis is still a potential life-threatening emergency. The group in Oxford, must have been 15 plus years ago, devised a very simple rule of thumb. If on day 3 your patient is still passing 8 stools or more, or has a CRP of over 45, they've got an 85% chance of needing a colectomy on that admission. And you and your service have got to be geared up for that. But I'd like to move on to rescue therapies. Intravenous cyclosporine is effective in inducing remission in acute colitis in about 80% of cases. So it's a good treatment. It's probably not been as popular and taken up as well as it should have been, because the initial dose used was 4 milligrams per kilogram per day, and this caused a lot of side effects and intolerances and other problems. It's now been shown that half that dose, 2 milligrams per kilogram per day, is as effective with far fewer side effects. You probably should avoid it in patients with significant renal impairment for obvious reasons. However, if you look at this group of patients to see how they do over the next decade, studies have shown between 58 and 80% will actually require a colectomy in the next 7 to 10 years. However, it is still a very useful treatment in patients who are at their first presentation are staggered by the fact that they might need a colectomy. Patients who are otherwise resistant to surgery, and can be used in this group of patients as a bridge to starting immunosuppressive therapy with agents such as azathioprine or lacaptapurin. Biologics have been used in many diseases, rheumatoid arthritis, etc., and also in inflammatory bowel disease. There is encouraging data on the use of infliximab in acute ulcerative colitis. It's probably not as good, the outcomes are probably not as good as IV cyclosporin, but logistically it's a far easier drug to give. Initially, probably a better side effect profile, and there's no issue with regard to measuring levels, etc. The dosing regime is very simple. You give an initial dose 0 weeks, 2 weeks later, and a further dose at 6 weeks. However, if the first 2 doses haven't made a major impact, it's probably not going to work at all. Side effects include infusion reactions, and you can actually have an anaphylactic reaction to this agent. Demyelination has been reported, worsening of heart failure, and if patients have NYHA class 3 or 4 heart failure, you really shouldn't be given infliximab. Cytopenias have been reported, and extremely difficult to treat malignancies have been reported, particularly in younger men who are also on azathioprine. There's been reports of hepatosplenic T-cell lymphoma and deaths related to this. Obviously, the biggest worry for all of us is infection. There's been plenty of reports of recurrence of TB, and you should really be screening your patients prior to starting infliximab for previous exposure to tuberculosis. Azathioprine and 6-methylcaptopril, I think, are the mainstay of therapy. If you came to sit in my inflammatory bowel disease clinic, I would have thought at least half, probably more. Sorry. Is that okay? Can you hear me? Yeah, great. Sorry, as I said, if you came to my inflammatory bowel disease clinic, you'd find vast numbers of patients on azathioprine, 6-methylcaptopril. It's very useful in patients who have steroid-dependent or refractory inflammatory bowel disease. Has a huge role in patients with fistulating perianal disease, and it's pretty well tolerated in probably 80% of patients that you try it in. As you all know, azathioprine is converted to 6-methylcaptopril, and if you probably had an American speaker here, he would be advocating 6-methylcaptopril first and azathioprine second. I'm never quite sure why it's been different on different sides of the Atlantic. I think you must, on a medical legal note, do a therapeutic methyltransferase level prior to starting patients in azathioprine and lacaptapurin, and we have documented in our protocol for nucleotids that this blood test is routinely performed. This is to ensure that it's safe to give the drug, that patients can metabolize it, and you don't end up going down the toxic metabolic pathway and causing cytopenic problems. The important thing to remember is that it doesn't work instantly. You've got a lag time of about 3 to 6 months before it really exerts its effects. It's not indicated for acute flare-ups, and it does have problems with GI side effects. 6-methylcaptopril probably is a better tolerated drug overall. There have been plenty of studies showing that both drugs are safe in pregnancy. Probably a good rule of thumb is for successful pregnancy outcomes, even in disease or remission, rather than worrying about the drugs overall. Surgery really has some very important roles and has changed dramatically in the last 5 plus years. It has a role, obviously, in the acute presentation of colitis. which is important in refractory disease, and once you develop dysplasia or malignancy, it is important that we do treat these patients with urgent surgery. And there are also a group of patients who are resistant to long-term therapy. I think the important thing is choose your surgeon, work in partnership. With the acute cases, you should be hand in hand. If the patient in the acute situation needs an operation, go for a simple operation, not for a difficult operation. These days, we've got surgical colleagues who can do things through amazingly small incisions. I've got 3 colleagues who can take out your whole colon through an incision, barely 2 or 3 centimetres across. Single pore colectomy is with us. The specimen is removed through the stoma site. And these patients can go on to have successful pouch surgery, 2 to 3 steps in the future. Obviously, surgeons have complications, and that includes small bowel obstruction, infections, leaks, port vein thrombosis, and later on we can still get problems with strictures that may need dilating, pouchitis, reduced fertility in women, and that is something we have to counsel women for, and obviously pouch failure and poor function. Long-term studies have shown that approximately 20% of patients who have pouch surgery in the long term do have nocturnal incontinence. Just got a couple of cases to run through that were quite challenging for us in the last 6 months. The first case was of an 18-year-old lad. He actually had a 2-year history of blood diarrhea, terrible symptoms, and had lost about 10 kilograms in weight. Quite amazingly, really, we still don't understand it. He didn't disclose his symptoms to his family, and his family didn't quite understand why their son was wasting away in front of them. He was a non-smoker. He fitted the criteria for acute severe colitis, he had a low albumin, an iron deficiency, anemia. His bowels were open copious times during the daytime and at night, and he had a terrible abdominal X-ray with a dilated colon. He was treated conventionally initially with intravenous steroids. There was a huge amount of time and effort put into discussions with the patient, his family, the colorectal surgical team, the stoma therapist. But at the end of it, he said, "I'm not having surgery for full stop." And he had, as we would say, capacity, and he improved slightly with intravenous steroids, and then went on to have intravenous infliximab. He did well, went home 10 days later, and was started on azathioprine and oral prednisolone. Unfortunately, 10 days later, he was readmitted in a terrible state. He was shocked, he had a tender abdomen, which is an urgent CT, fearing worst. There was no free gas via this tatty, dilated-looking colon. And we literally had a life or death discussion with him. And even at this point, this young man was really not very keen on surgery, and we had to really twist his arm to consent to the procedure. We went to theatre, and my surgical colleagues really gave us some quite frightening information. His colon was a dusky blue colour. There were microscopic tears throughout the transverse colon and cecum, and he was probably hours away from fecal peritonitis and possible death. And really reminded me of the fact simple, safe surgery and experience has is probably still the best way forward in this group of patients. Another recent lesson was a 28-year-old lady with 1 child. She came in with acute diarrhea, stool cultures were negative, her inflammatory markers were elevated. She had a flexible colonoscopy which showed really terrible inflammation on the left side of the colon. She was treated conventionally. She settled down and went home on oral steroids with a view to azathioprine. She was readmitted 2 weeks later with a recurrence of the symptoms, and her inflammatory markers were again raised. Just to check you're all still awake, I've given you 2 options here: cyclosporine and infliximab or surgery. Okay, those of you going for cyclosporine or infliximab, arms up please. Okay. Fine, and those of you going for surgery? Those of you standing on the shelf. Right, well I've been slightly unfair to you, because she had stool specimens sent off, and she was in fact C. diff positive. She'd been C. diff negative 2 weeks previously, and and she improved with antibiotic stereotherapy and went on to azathioprine. Got one final last lesson. This is a case that I was told about when I was a registrar and it stuck with me for 25 years, and I've sort of recounted it numerous times. I was working in a tertiary referral centre for inflammatory bowel disease, sucking patients in from a population of over 3 million. There was a 25-year-old lady, married female, who came with an acute case of colitis, didn't get better with the usual treatment, and we were in a very surgically based unit, and there was a decision to surgery. She went to surgery, did really well. Now, I don't know if you know many histopathologists, but I know a few, and they don't really get excited. They're not excited to be people. We've got an urgent phone call from a histopathologist, and he had found tons of amoebas with the colonic specimen. We went back to her and said, have you travelled and done this, that, and the other? And we then went into this a little bit more, but my predecessors looked into this a little bit more, and she had an Asian husband who then said he actually had chronic diarrhea, and there were his stools were teeming with the hospital at that stage had to settle for quite significant damages 25 years ago. Again, a great lesson. So to conclude, check you've got the right diagnosis, truly any condition. Always exclude infective agents. Always send off the specimens. If they're acutely unwell, make sure your surgical team are holding your hand and doing this together. Make sure they're doing simple operations in the acute situation. Please don't give repeated courses of steroids without it. You've got to have another strategy. Think of alternatives. And always have a rapid access back into your service for your outpatients or sick patients. Thank you very much.
Thank you very much for comment. I open the floor for discussion. Any questions?
Question from here.
Thank you, Dr. Liban. Actually, we have a lot of patients that they are undetermined colitis. So they are not Crohn's disease, not ulcerative colitis. So in your experience, do you think that surrogate markers of such diseases, such as fecal calprotectin or ASCA, ANGA, may help us to shift this diagnosis of indeterminate colitis to one of those two big categories, ulcerative or Crohn's?
I think the fecal calprotectin is a very useful test for gauging flares in patients. Some patients, as we all see, don't raise their inflammatory markers even though they've got pretty bad disease when you scope them. And fecal calprotectin is a reliable, non-invasive test to quickly assess them. I don't think it has a role in differentiating particularly between UC or Crohn's. I think it's just a marker of acute inflammation. Obviously, if they've got PSC and PMK positive, pushing towards those possible colitis.
Question?
Inflammatory bowel syndrome is inflammation of the intestine. Then instead of between pH1 and pH2, this is an inflammatory cytokine is high. If we can, the balance, we correct it by pH2, that is interleukin 10. Instead of giving all these drugs, can we improve the patient or continue?
You mean by attacking the cytokines themselves? There have been various... Sorry.
Interleukin 10 or but pH2 now is low,
Yeah.
pH1 is high.
Yeah.
If we can correct the balance, can we, the patient improve without giving all these drugs, dangerous and thank you.
Thank you. I think you're right, and there's been plenty of studies showing the cytokine changes that you've stated, and some of the treatments do make some improvements in that. There's been no specific treatments that have found a way of rebalancing the cytokine imbalance, as you've stated. There were novel therapies used probably about 10 years ago using intravenous or subcutaneous heparin, which was found to have made some changes to the way adhesion molecules and things work. And that was quite a novel therapy, but trials of that didn't show that it was efficacious in patients with UC.
Dr. Ihab, last question.
Thank you very much for this very nice presentation. My question is regarding other anti-TNF factors. What's their role in the UC now? I mean, we know infliximab is the only one that's really been approved.
Yeah.
But what about the other TNFs?
I suspect the makers of the others will be doing their trials in due course. I think the problem in UC is the whole equation's changed with the changes in surgical technique. And a lot of patients, when you counsel them with regard to coming up, say, for infliximab infusions every 8 weeks for years, potentially for a year or two, all the risks of that combined with a suppressive therapy with an ACI. These days, when we're finding more and more, when they really get into and understand the surgical outcomes, much better prosmesis, a lot of patients are moving that way. I suspect that moving that will be the next one to be licensed in UC in the UK.
The British guidelines always say about evaluate after 1 year of using biological therapy.
Yeah.
What do you evaluate and how do you decide to continue with biological therapy or something else?
Yeah, that's right. That's exactly what my guidelines say. We tend to reschedule patients at a year to see whether they have active inflammation there, take biopsies, and then have a discussion with the patients. Also, we look at what's happened to them in the past. Some of them have had a torrid time, and it's the first time they've actually had control and got back to what's normal life. And even if they're in remission, then I tend to probably give them another year before trying to stop them.
Thank you. Good question.
Thank you very much for this excellent lecture. I have two questions. The first one is that we know that there is a incidence of pneumococcal and bowel disease. So do you suggest prophylactic anticoagulation for all the patients and for how long? My second question, a female with a very bad past history of severe ulcerative colitis, but she's doing well on infliximab. With the implant, he became pregnant. So do you think that if we shift her to prednisolone and other therapy, that is enough to control the patients and protect her from getting relapse, or there is an alternative choice?
Okay, two excellent questions. The patients who are in hospital in the UK, there's a big purge on trying to reduce the incidence of thromboembolism and death and problems related to it. So virtually all of our inpatients, as soon as they come into the hospital, are treated with prophylactic doses of TARA. I don't think there's any evidence to say that once they're up and around and out of hospital, they need to continue. The second question with regard to infliximab in patients who've been difficult to control and don't get pregnant, I think that's very difficult, very, very difficult group of patients. To my knowledge, the safety data in pregnancy isn't that robust yet. I think it is probably going to go up, but it is safe to use in pregnancy. However, I think it's obviously a potential high risk, also a potential high risk strategy. I must say, in my patients who are on infliximab who've gone into remission, I would try and get them off and put them on azathioprine. And the manufacturers, I think, recommend a washout of about 6 months before the patient gets pregnant. Obviously, if it's happened without planning, then that's a different issue. I must say, I personally try and avoid the azathioprine steroid to get a combination of chronic disease.
Okay, thank you very much. Our next speaker again is Dr. Dora Kenneth again, but now he's going to talk about interventional endoscopy, not implant. inflammatory bowel disease now.
Thank you. I'd like to talk about interventional endoscopy. Really, to just outline a few of the things I'll be talking about. I think standards in endoscopy are vital. Training for people to do basic endoscopy is critical to generate people that will want to do therapeutic stuff. I'll just briefly outline what we're doing today. I hope to demonstrate the blurring of the interface between endoscopy, surgery, and interventional radiology these days. And I think what we can offer patients very much depends on our local expertise, the kit available, and obviously the patient's wishes. Back in the 1990s, endoscopy in the UK was in a bit of a dire situation. All sorts of people were endoscoping. There were general physicians, geriatricians, gastroenterologists, general surgeons, breast surgeons, colorectal surgeons, upper GI surgeons. And it was recognised that this all needed some form of governance. So a group of august bodies, including the colleges of physicians, the colleges of surgeons, specialist societies in upper and lower GI cancers, got together and formed a joint advisory group on gastrointestinal endoscopy in 1994. And really, they have really helped to turn the tide of UK endoscopy with regard to training and standards. They define standards for all endoscopists, irrespective of their professional background. This was at a time in the UK where we were really struggling with demand. We're struggling again with demand. It was terrible at that stage. A routine procedure, you could wait anything up to 6 months. I remember diagnosing a cancer in a 70-odd-year-old lady 32 weeks after she was referred for a colonoscopy. A terrible situation. And we really wanted to develop nurse endoscopists to help with this volume issue. As I said, JAG sets standards for individual endoscopists, and more importantly, they set standards for training for all of us. They started quality checking our endoscopy units and quality checking endoscopy courses. As you're all aware, courses are a great way of making a lot of money for people, but the standards of them can be very variable. I would commend those of you that haven't been to go to this website, really to have a really good look at how quality can be assessed in most services. So from 2005 onwards, JAG set up a program of inspecting all units that did endoscopy. This included acute hospitals, non-acute hospitals, and now the private sector. And this has been a process of evolution. And as in most peer-reviewed inspections, the standards have risen over the years. On the background, the so-called endoscopy global rating scale was devised. This really measured clinical quality, things like how much sedation do you do, how often do you have to reverse sedation, do you have a poor outcome throughout ERCP, colonoscopy, how often did you get to the cecum, how many polyps did you find, other such things. They also looked at the quality of the patient experience. Did we look after our patients properly? Were they consented in a way that was appropriate? And did we look after their comfort scores, etc.? Look after their comfort. We also have to look at our workforce. Did we train our nursing staff appropriately and educate them? And obviously, as I mentioned, we also looked, JAG also looked at endoscopy training. From JAG evolved JETS. That's the JAG endoscopy training portfolio, which is an e-portfolio-based system. As some of you may know, UK medical trainees are burdened by e-portfolios, but it is a great way of documenting their progress, particularly in endoscopy. It documents their endoscopic experiences and their ability to improve. It's very easy to set standards that they should get to, look at personal development plans, record courses that they attend, and do DOPSIS on them as they train. The important thing is most of our trainees rotate through 5 or 6 hospitals. It is portable. The next boss can look at the trainees' performance and see where areas need to be strengthened. And the other interesting thing is the reflection for us as trainers. The trainees are able to feed back to us as trainers in a totally anonymous fashion. As I said, it sets standards. The JETS portfolio and JAG have set standards for endoscopy training, and at the end of your training, we perform what's called a summative DOPS, where we have two independent trainers watching someone's scope a couple of cases to see if they've reached a standard where we can sign them off for that particular procedure. And this happens throughout their careers as endoscopists, so basic endoscopy, therapeutic endoscopy, colonoscopy, ERCP, EUS, etc. And as I said, each set of procedures has its own defined standards and importantly auditable outcomes. This has bred a great culture of audit within the endoscopy fraternity, so that every 4 to 6 months, every NHS unit in the country will circulate amongst its endoscopists and a few other selected people performance figures. This will look at how much work you've done, how well you've done it, your safety, and complications. And in a lot of units, this is no longer anonymised, so it's open and there for everyone to look at. So really, moving on to what we can do today, and I'm just listing some of the things we can do. This is not a totally inclusive list. There is Botox injections for achalasia, targeting the patients that are frail, elderly, who can't have balloon dilatation, who can't take the risk of a balloon dilatation or surgery for achalasia. The other group of patients we're seeing more and more of, probably with the epidemic of obesity and type 2 diabetes and poorly controlled diabetes, is diabetic gastroparesis. A lot of patients have probably recurrent vomiting, gastric stasis, and they seem to do reasonably well with Botox injection around the pylorus. Esophageal dilatation has been around for many years and really now concentrates in the UK on benign disease. Malignant tumours are virtually never dilated per se. Every now and then our patients kindly swallow various objects that we have to try and remove. That's always an interesting test of skills. As I've mentioned, we can balloon dilate for achalasia. I think this is probably a practice that is going slightly out of fashion with the advent of better and better laparoscopic surgery and cardiomyotomy. There's a whole variety of stents that we can put into people these days for benign or malignant indications, post-operative leaks, recurrent benign structural disease. And these can be removed or permanent in the case of cancers. And we've also, as I think Miles mentioned earlier on, we're probably ahead of the cardiologists in that we have been using biodegradable stents for recurrent benign structures that dissolve away in about 12 weeks. Quite expensive, nearly £1,000 a shot. We can feed patients in various ways, percutaneous endoscopic gastrostomies, percutaneous endoscopic jejunostomies for patients with reflux issues, and also nasojejunal tubes. And I think the nasojejunal tube is a very important device in the ITU situation. The patient who's on a ventilator for a long time, developed gastroparesis, putting in an NJ feeding tube can help you get off TPN and all the risks of TPN. Going back to PEGs, I think PEGs were technically a very nice thing to do. However, the outcomes in the UK have been very poor, with poor 30-day mortalities, and there is a major swing away from doing PEGs without very detailed MDT discussions on the outcomes, survivals, etc. of patients. We don't PEG patients who have got dementia, for example. Again, going back to the fatty liver talk earlier on, we're seeing an epidemic, particularly sadly where I live in the northeast of England, of people growing and growing. And a lot of my colleagues are putting gastric balloons in to help to shrink people down prior to definitive obesity surgery. I think all therapeutic endoscopies worth their salt really should be good at controlling upper GI bleeding these days. We have a whole armamentarium of things that we can use: adrenaline injections, heater probes, endoclips, and argon plasma coagulation, and the new HEMA spray, which is a great spray that you can spray down when you can't see what's going on, that helps to activate clots almost insustainably, so that we can start to treat in a different way. Banding, stents, and balloons, and glue can be used for treatment of varices. The next talk is on colon cancer screening, and I'm not going to steal any of the thunder there, but we know that polyps become cancers over probably a 10+ year period. We now have very advanced polypectomy techniques and screening programs to remove polyps of various sizes. And it now stands with the size of lesions in the thin right colon that can be removed by skilled endoscopies. Some lesions across 3 to 4 centimetres. And there are ways of doing this with very minimal perforation rates. The Japanese are probably way ahead of everyone in the world with regard to what they can do endoscopically. But they will spend hours doing these procedures. Again, we become pretty efficient at stenting patients with colon cancer, either as a palliative or as a bridge surgery. I'll talk a little bit more about that a little later. EUS has really not taken off in the UK, in that it tends to be centred in bigger units, but it still has a big role in tissue sampling for patients prior to surgery and chemotherapy, particularly in incompatibility malignancies. Again, important in the staging. And there's the other group of patients that we see who have severe pancreatitis, either gallstone or alcohol-related, who have large pseudocysts. There are plenty of techniques now to drain these directly through the stomach. Again, EUS can be used to perform celiac plexus blocks in patients with cancer and severe painful chronic pancreatitis. ERCP is an area of my own interest, and I think the first question is safety in ERCP. It is one of the things we can do as endoscopists that can finish patients off, and you have to be really careful and make sure you're doing the right patient, and doing the right procedure. And the first question is, do you need to do it? You're not just doing it to enjoy doing it, there's got to be a useful therapeutic outcome. There's a big move in the UK, and the BSG are about to publish guidelines on this, and those of us working in district general hospitals are slightly nervous, and that they will start to promote bigger regional centres, not only for malignant disease, which is already the case, but also for level 3 benign disease, i.e. the trickier stuff. I think the cornerstone to good ERCP is high-quality imaging. You need to be able to get triple-phase CT and high-quality MRI, both non-invasive. I've never known anyone die because they've had a CT or an MRI, but I have seen people die from ERCP. We should all be able to minimise our risks, and the biggest fear of an ERCP is pancreatitis, and there are now easy-to-use pancreatic duct stents that minimise this risk, and rectal NSAIDs have been shown to be efficacious. The size of stones that we can deal with is just colossal now. We go from a few millimetres across to the massive 3 or 4 centimetre stones with clever devices that can crush stones, and now through the scope lithotripters that can shockwave stones to fragments that can be removed. Strictures can be visualised directly with mother and baby scopes, and we can brush them, biopsy, and as I said, directly visualise. And this can help to differentiate between the benign and malignant stricture. We have a whole variety of stents that we can use in ERCP, and I can bore you all with all the different types of stents. But I think one of the important factors is a plastic stent in the UK costs approximately £30 to £40. A metal stent is around about £800 to £900, depending on the manufacturer. And you have to look at life expectancy, recurrent admissions, etc. However, the weight of evidence probably points towards putting metal stents in most patients. These come in various guises of covered, partially or uncovered, depending on what the exact underlying pathology are. We're also encouraged to intervene at a much earlier stage than we ever did before in cases of acute pancreatitis. If the patient is jaundiced, we've got imaging such as an MR, CP that confirms a stone, get in there within the first 20 buried somewhere in the middle here, and there's a lot of mucosal edema there, always tricky, and I would advocate a simple thing like giving a little bit of buscopan just to open that up so you can do. Now this is the one that you should develop a little bit of a tachycardia when you're endoscoping this sort of patient. You have a time window before the patient exsanguinates in front of you. Various therapeutic options that probably you should all be familiar with. Good old-fashioned 1 in 10,000 adrenaline, been around for 25+ years, reduces rebleed rates very successfully from 15 to 15% when you've got visible vessels, 35 to 10 when there's adherent clot. Initially, we were very conservative as physicians, really. We inject 3-4 mils, and that was it. Now there's good evidence to show the more you give, the better the outcome, the less the rebleeding. The only downside is there is a slight increase in perforation rates and pain. 30 mils is probably option, or the other way of looking at it is you must give more than 13 mils from a big meta-analysis. We've got various thermal treatments for bleeding ulcers. We use gold probes, argon plasma coagulators. The benefits are about the same as with adrenaline. And you basically cook the ulcer until it goes black. Again, perforation is reasonably rare. Oops. I think endoclips have been one of the greatest advances here in the last few years. Various companies make them now. We've moved to ones that are rotatable, we can open and close. And I think one company makes one where you've got 4 or 5 loaded up together. They basically, you probably get a better hemostasis with clips rather than injections. A lower rebleeding rate, much less need for surgery. Probably equivalent to thermal therapy, but I think anyone dealing with bleeders now should be comfortable using clips, as should your endoscopy assistant nurses. So basically, with regard to bleeding, you do 2 things: injection plus clips plus something. The rebleeding rates, the need for surgery, and the mortality rate all decreased by doing 2 things rather than 1 thing. So become skilled at something, do 2 things. The other important thing is the second look endoscopy. The first look is normally a bit fraught. The patient's a little bit unstable. And sometimes it's worth doing the initial hit, stabilizing the patient, and bringing them back within the next 24 hours to have another look. But you have to decide when to bail out. Eventually, there's nothing more you can do, and that's when you have to have your interventional radiologist at the side or your local friendly surgeon. I think overall the future for surgery for endoscopy is great. I think the future for surgery is going to change remarkably. The surgeons in my hospital are just not used to operating on bleeding ulcers. I think we've sent 1 or 2 people in the last 2 years for surgery. You've got to think about MDTs for benign as well as the well-established MDTs for malignant work. We're all going to get busier and busier. As I said, the UK is constantly catching up, and the next talk on colorectal cancer screening is another big pressure on the whole service. We're going to be dealing with older, frailer patients, and you have to look at each patient on an individual basis. My oldest ERCP patient was a lovely lady who was 102, sat up an hour later reading her book after the procedure, lived until she was 104. We're doing more complex work that's technically more challenging, and I don't think midazolam and opiate is good enough sedation, and it also distracts the endoscopist. The Americans are ahead of the game, and they're giving propofol to these patients, and it makes it much more easier. And I think, as in all procedural-related things, we're heading towards centres of excellence where some of the procedures I've described will be sucked in. Many thanks.
Thank you very much, Dr. Darshan, for this excellent talk. There's room for 1 or 2 questions if anyone wants to ask. If nothing, we all are clear. Thank you very much again. Thank you very much.